All right, everybody. Thank you very much for joining us today. My name is Jonathan Bush, and I lost my place, but I'm going to find it. Welcome, everyone, to our first lightning rounds, powered by Zus, where big ideas in healthcare get a jolt. I can't show you this because of the background, but it's coffee, which I spilled on myself as we were preparing. We're going to have a webinar that is interactive. Hopefully you have all seen that little poll pop up, so we're getting a little background. There'll be other polling later on in the conversation. And of course, there's the chat button for you to add your questions and comments and retorts to the conversation as we move along. Guests today are legendary. We have a really good panel here. Avik Roy is most important to me. Well, he was the healthcare editor at Forbes and chose to interview me, which, of course, I like people who like me a lot, especially when I was very early in my Athena Health story. But he subsequently founded FREOPP, the Foundation for Research on Equal Opportunity, which focuses on market-based reforms that disproportionately affect the bottom half of, economically speaking, a bottom half of income earners in the United States. He was just recently president of the National Institute for Healthcare Management and is a dear friend. Toyin Ajayi, co-founder and CEO of Cityblock, which serves a marvelous function, particularly relevant today, surveying, identifying those in most needs, and targeting for extra help Medicare and Medicaid, Medicare combo beneficiaries around the country. Cityblock has been an incredible story to watch, both as a client of Zus and as a fanboy from the outside who started his life driving an ambulance in New Orleans, watching the same untargeted folks re-hit what was then Charity Hospital hundreds and hundreds of times a year with no reset button. Similarly, Neil Batlivala is the founder and CEO. Go ahead, Neil, hit it.
Batlivala.
Batlivala, that was my next, is the founder and CEO of Pair Team, which focuses even more intensely on those acute cases, literally treating people in their homes, if their home, even if their home is under a bridge, with taking on their acute mental illness and their social dislocation in order to get them back on track. Both companies have enormous impact on basically our self-respect as a society for finding the people that get left off, but also for the cost of our safety net, because these are the people who in the Camden study famously, it was not an 80-20, but a 92 rule where 2% of the population are just driving 90% of the spend by not ever getting their reset buttons hit. Now, the rule for this hour, we're going to start with a little bit of what is this BBB that DJT has gotten through by the skin of his skin, and what are the implications for policymakers, for people who play in the Medicaid space, and for the states themselves that administer these Medicaid programs. That'll be a table setting session. We will then go into what Toyin and Neil are doing about it in their business, which are extremely Medicaid dependent, and what lemonade they plan to make out of it, and what ice they plan to apply to the bumps that may be applied to their head from this. From there, we will pop up occasionally with some polling questions, and then we will get to your question. And the whole thing will be done in about an hour from now. Any questions? Tough. It's too big a group. Avik, talk to us about what this thing is. And you can include other things besides Medicaid if you think it's relevant, because sometimes there's fine print that trickles off into all manner of society that affects the healthcare system besides the straight Medicaid program. But what was it? How did it go? What are the implications for states, their plans, and the businesses that serve them?
Well, Jonathan, it's great to be with you. And as a fan of Zus Health, it's great to be able to spend some time with your stakeholders and the people who are working with you to improve primary care. So important of a mission. In terms of the OBBBA, I always forget how many B's to put in there. The simplest way to describe it is it was an extension of the 2017 tax cuts, for the most part, which the Congressional Budget Office scored as costing or increasing the deficit by about $4 trillion over the next 10 years. And so Republicans decided that they would partially pay for those tax cuts with reductions in spending in other categories. And one of those categories is Medicaid. That's not the only category. There were some reforms of student loans. There were some reforms of energy spending, but reducing Medicaid spending was a significant component of the overall picture. But just to be very clear, when I say reducing Medicaid spending, I'm not saying that the actual number of dollars that's being spent on Medicaid is going to decline in the future relative to what it is today. What I'm describing is that the projected amount of spending in the future will decline. So to give you some actual stats, in 2023, the federal government spent $591 billion on Medicaid, and the states spent $280 billion on Medicaid. By 2032, the CBO projects that was going to be $869 billion on the federal side and $518 billion on the state side. So a significant increase of almost 50%. And Medicaid spending increased by another 50% if you look back just 4 or 5 years from COVID, the COVID era to now. So Medicaid spending has dramatically increased, and Congress decided, let's try to reduce the growth of Medicaid spending through a handful of reforms.
Talk to us quickly about the reforms versus just the restrictions and how that was balanced.
Sure. So obviously, different people have different points of view as to the merits of what Republicans did. If you asked them, why did they pursue the particular policies they did? Here's what they would say: the big chunks fiscally, in terms of where the most savings came from, were things like cracking down on the enrollment of undocumented immigrants in Medicaid, which is theoretically something the federal program does not support, but a number of states have found ways around that, basically. So the new reforms basically make it harder for states to enroll undocumented immigrants in Medicaid. That's number one. Number two, they introduced what they call community engagement requirements in the Medicaid program, which require people who are enrolled in Medicaid to either work a minimum of 20 hours a week, if I don't have the number correctly, or look for work for 20 hours a week. So you don't have to actually necessarily work. It can be attending job fairs. It can be volunteering. It can be caring for a relative. In fact, there are a number of carve-outs if you live in a locality where the unemployment rate is significantly higher than the national average. So if you live in an area that's more economically depressed, you're not subject to these requirements, nor are you subject to them if you're disabled, if you are a mother with young children, pregnant, et cetera. So it doesn't apply to everyone, but it particularly applies to able-bodied, non-elderly adults. There were a couple other things in there that were pretty fiscally significant. The most important is there's basically this kind of money laundering scam that hospitals were using to draw additional money. States and hospitals were using to draw additional money from the federal government to basically increase what they spent on hospitals. This was something that for many, many years was a bipartisan target for fiscal policy. For those of you who remember the Simpson-Bowles Commission from the Obama era, that was something that this bipartisan commission recommended for closure. Biden, when he was a senator, recommended it, and also as vice president for reform, and Republicans did put some effort into reforming that, or at least limiting the growth in these provider taxes and state-directed payments that were basically funneling extra money from the federal government to hospitals through tax increases. So that's something they cracked down on. That was also a significant savings. So those were the three big buckets. And again, lots of different views out there as to what the impact of those reforms or changes will be on the Medicaid program. But I think if you ask Republicans, what they would say is everyone's saying there's a lot of waste in the healthcare system. The line that people used to use 15 years ago during the ACA debate was that a third of healthcare spending is waste, fraud, and abuse. And Republicans would argue that they're trying to tackle the waste, fraud, and abuse through those big reforms.
Last one before we get to the celebrity guests. What do you hear the states doing as a result? I mean, it's sort of conceivable that with the 20-hour commitment, the Congressional Budget Office could be very surprised. People say, screw it, I'll go do the work, and the number goes up. But how right now are states responding, or at least saying they're going to respond at this early stage to make adjustments, or do they have to?
Well, it's a little early, so we don't yet know how they're going to respond, but we do have past history to go by. So, for example, in the mid-1990s, in 1996, there was a reform of cash welfare under President Bill Clinton, which was similar. It imposed work requirements, a very similar model to the ones that Republicans enacted this summer. In fact, the ones that Republicans enacted this summer are modeled almost exactly after the ones that were passed in 1996 for the traditional cash welfare program. And what we observe in that cash welfare program is that the enforcement of these work requirements or community engagement requirements is pretty inconsistent, right? So basically what happens is somebody comes into the welfare office, and a case officer will ask, "Hey, did you go to a job fair this week, or did you work this week?" And if the person says yes, then you can check the box and move on. I mean, there's not a lot of aggressive auditing or inspection of these statements. So it's kind of an honor system up to a point. I'm oversimplifying, but I bring that up to say that states that are concerned that people might lose Medicaid coverage, a lot of times what happens is the case officers who work in those departments find ways to try to protect and ensure that there's continuity of coverage. Now, that doesn't mean there won't be disruptions. And the Congressional Budget Office certainly believes that there will be people who lose Medicaid coverage because of these changes. But I think, again, when we look at the history of the welfare program, that's how states have often responded.
Yeah.
Another piece of it, of course, is that there are people who are eligible for exchange-based coverage who are in the Medicaid program either erroneously or for other reasons. And so you may see shifting from Medicaid into ACA exchange-based coverage or employer-based coverage. And so it's not that if you aren't on Medicaid, that necessarily means you won't have insurance. It may be that you just get coverage through another mechanism.
Right. Of course, we have that as a normal part of American life today. Oh, my wife's in the fire department. They have amazing benefits. I think I'll, go as a beneficiary instead of going at your cheap ass tech startups coverage or whatever it may be. Toyin and Neil, let's start with you, Toyin. What have you seen you've heard the sound of the gun going off, but the missile hasn't sort of made it across the valley. What are you guys seeing, hearing? I guess, yeah, seeing first, hearing second, and doing third so far.
Yeah, I mean, first of all, thank you, Avik. I thought that was really a wonderful sort of setting the table in terms of what we're dealing with here. I think it's still early days, and we've seen a lot of this movie before, like in pieces, right? So if you remember post the public health emergency coming out of COVID, the Medicaid program underwent a significant process of redeterminations, right? So we had about 90 million people on Medicaid coming through the public health emergency, at which point there were prohibitions on disenrolling people. In 22 and 23, states went through the redetermination process. And through that process, about 15 million people who had been on Medicaid no longer had Medicaid. There was the whole process of sort of proving your eligibility and reproving your eligibility. And what that did actually for a lot of states and for folks like us who work with Medicaid members is that it gave us a little bit of practice in how to do this and some experience around what it looks like. Specifically, the administrative sort of process of saying, hey, my name's Toyin. I believe I'm eligible for Medicaid for these reasons. Here's the paperwork I need to submit. Here's the back and forth to ensure it's fully correct. Here's the relationship between me and my health plan. If I've moved address, how do we update the roles? There's a lot of just sort of like administrivia that either makes or breaks this. We've seen some of this movie before. And so we're sort of gearing up to support our members who, by and large, because we serve high risk and rising risk folks in Medicaid, will continue to have eligibility through that. So that's one piece. I think there's a second piece that is a sort of maybe a cautionary note for us that we are cautiously optimistic will be incorporated as the rules actually are promulgated. This is where the devil's really in the details here, right? Like, what does it actually look like? What is CMS saying to states? What technical assistance and support are they providing? What's inbounds, what's out of bounds, et cetera? And where is their discretion for states to play here? We have really good evidence from Arkansas, which voluntarily initiated work requirements a couple years ago, that by all accounts, it's not a partisan question here. The data supports didn't go well, right? It was administratively incredibly taxing, did not yield the savings financially that they expected. And a large part of this is because what we know now, and I think a number of studies have sort of validated this, is most people on Medicaid, especially post-redeterminations, would qualify and would meet the work requirements threshold. So folks are working, or they're students, or they're caregivers, or they're exempted from work requirements because they're pregnant, because they are a mom with small kids, because they have a person with disabilities. And so there's not a whole lot of really like low-hanging fruit here to go after. And the potential that the administrative sort of burden of just going through that process of forcing people to attest could actually erode whatever potential savings there are, right? It's an opportunity, though. I mean, we're all
Like a revenue cycle, okay, show me the receipts from the school, show me
right.
it's a new billing bloat to prove that your people fit.
But the optimist in me says, look, hey, we're all like tech people. And then actually, this administration has done a really nice job to their credit of attracting folks with tech backgrounds to do really important jobs within CMS. There's just been a consistent focus and emphasis on saying we've got to modernize all of this bureaucracy. And so here's an opportunity to say, look, actually, let's automate as much of this as possible. Let's leverage real-time data flows between IRS and Medicaid and CMS and providers and start to make it easier for people to qualify if they do qualify and to understand what their benefits are. And I think if we are, forward thinking and determined to do so, there could be some real upside here that and value that accrues far beyond the sort of use case of work requirements, but beyond that, to sort of think about how we qualify people for and help them understand and access a whole host of benefits, including social benefits. So there's a potential upside here. I think the big thing is we're racing against the clock, right? And the timeline for implementation is really short. And so my hope is that there's some effort here to move quickly to both promulgate rules that are clear, actionable, and that require comprehensive collaboration across multiple parts of our health and social services ecosystem.
Neil, you strike me, not you, but Pear strikes me as a program. Cityblock is surveilling everyone, finding the folks that are sort of at the highest end of the needs and the lowest end of the mean spectrum to target them. And you're the kind of one of the people that one would call when you find that person. So I find it hard to imagine that, a lot of the Pear team people are actually, perfectly able to quietly working at a bank with no one, noticing or whatever. Is this just not going to hit you because you're at the other end of the pool?
No, it's gonna hit us. I'll just to walk through it. I think what we're seeing is we're definitely seeing, anxiousness from our frontline staff, our patients, particularly folks that are undocumented. So we got hit earlier on. We're primarily in California where they have universal coverage for undocumented individuals. That's going through a huge transition now. So that is and that's scary, right? That's folks, family members. You can no longer have these community health events, or you can, but there's the risk of ICE there. And, kind of these roundups that have been going on in California, like we're facing that day in, day out when we do community events. So that was like the first part of us hitting this on the ground. The second was we represent a lot of community-based organizations. So our model is to partner with the local shelter, the local food pantry, and actually integrate them to be a part of the care delivery system here. I don't know if folks remember, but back in early January, there was a funding freeze. It was for a hot 2 minutes, but it was a scary 2 minutes for a lot of folks because suddenly they had to figure out, what the heck am I going to do? Like, I no longer have money for the next week to pay my staff there. And so what we're seeing is community-based organizations looking to actually participate in the care delivery systems. This is a lot of what we do because it opens up new funding sources there. And in that way, we can actually kind of better coordinate care here. And Toyin, to your perspective about all being technology people, I think 100% we are looking at both the administrative components of it, but also the engagement components of technology. Because I think, to your point, like we've seen this movie before. I think it was New Hampshire. Don't quote me on that, but I think it was New Hampshire that implemented work requirements. And it was this, about 50,000 people. They tried to outreach to everybody to tell them that these work requirements were getting put into place. Only 500 or so folks were reached. It was only like a 90% reach rate there. And of the 90% that were reached, only 90% confirmed identity so they could actually hear about their enrollment status. And so it was very ineffective. It was very ineffective at least socializing that this stuff was happening on the ground there. So New Hampshire revoked it and pulled it out. And it just kind of speaks to me about the power of engagement here and what we're really going to have to focus on, which is building high trust, high engaged relationships with individuals to inform them about what's happening here and help steward them through these administrative hurdles, right? Everything that Toyin
Yeah, this seems like a big, actually a huge, when I think about the entire kind of digital first or digital present customer base inside of Zeus, there's a big role which we did not plan for, which is just figuring out who everybody is, where they are, what cell phone are they using, who are they staying with. This finding and attribution, was sort of the big bucket we call it, is a huge use case. And I guess with this new thing, and especially the way Avik describes it, attribution and sort of, what's the right word, sort of filing, as working or trying or caregiving, a fair amount of just social geography work before you get to any treatment.
100.
What percentage of your guys' lives is just that before you get into navigation, et cetera?
Yeah, I would say a significant proportion of that. And I would just add one more thing. This is to the point around promulgation of rules is so important. The policy, the actual writing of the policy is going to be critical here, because during redeterminations in some states, providers who are more likely than health plans to know exactly where these patients are, we're actually prohibited from helping people in filling out their documentation and attesting and calling the office to say, I am so-and-so, and I believe I'm knowledgeable, right? Other states said, actually, you know what, we'll take any source of information. We will allow providers to update us and let us know, Medicaid office, what the right current address for Jonathan is. Other states said, actually, we don't want to hear from you, right? And so things that is as simple as that make a huge difference. If we can empower and enable any possible person within the healthcare ecosystem who has contact information for people who are hard to find and hard to reach, to update that information so they're more likely to get the letter that says, hey, you got to fill out this form to retain your coverage. Something as simple as that across the country would make a real difference. Again, better than that, if we automated it, even better, right? But those are the types of things that are so important. We spent a lot of time finding people. And we know from the redeterminations experience, I think folks at CMS will tell you that when they were about to roll this out, they looked to all the national health plans and said, all right, we're going to need your help to go find these people. And unsurprisingly, many health plans said, look, we have no contact with a lot of these members. We pay their claims.
It's the wrong number, or it's, yeah,
We don't know where they are.
from the 90s. Do you feel like these sort of leading digital forward providers, sort of COVID babies, are you priming the pump? Is this a cleanup act that's kind of a one and done, or is there a bolus of kind of getting people mapped, craft, named, acted, connected to an app that will then kind of be usable as a resource going forward to better care for people and better make and obey rules?
Like, I could take a stab at this one. I think a lot about the source of how folks find out about you. How does someone find because at the end of the day, you could cold call, you can email, you can do all these things, right? But like, we focus a lot about getting awareness via community-based organizations, because those are the organizations that these individuals are going to. They are going to the local food drive. They are going to the local church, right? We have a partnership with Catholic Charities, for example. And through that means, you can then say, hey, here is a tool. Here is in the world of AI and agents, here is a member agent that can help support you on your form filling application there. But it does come down to, the avenue in which you learn about this there. And we actually submitted out there was a Medicare RFI that came out a couple months ago. And one of the things we advocated for was community-based organizations to be a formal part of TEFCA, to be a formal part of FIRE, the social support services that are received, and have utilization actually go through FIRE there. Because, Toyin, to your point, we're kind of flying blind. We don't know where folks are and when they are engaging with community-based organizations. And, this is actually one of the big opportunities we see at PAIR, is unifying this infrastructure, because it's not like the health plans don't know about it because they're only tracking things on the medical side of the world. There's the whole other non-medical side that folks are utilizing and engaging with. We just don't have any of the data tracks or any of the infrastructure on that side, which could do a whole lot of good to driving efficiency here and just making it better for patients.
Toyin, what do you think? Are we pumping through a bolus of work that's then going to be useful and more stable in terms of graphing people?
That is the hope. And I say this, I think it's not an inevitable path that we're on, right? Like there's a default path That is that we hack our way through this and we come out the other side and we've disenrolled a lot of people from Medicaid, many of whom actually were eligible, but just couldn't deal with the administrative challenges of proving that we as the taxpayer end up footing the cost when that person crashes into the emergency room with worsened morbidity as a result of poor access to care that they would otherwise have gotten. And we look back at ourselves and say, gosh, what a wasted opportunity. And we actually did more harm than good. That is a real and plausible outcome, but it is not a foregone conclusion. I think there's a bull case that's like actually exactly as you described it, Jonathan. Like, we're going to use this opportunity to get through a bolus of really important structural work that will yield value, like for all sorts of things down the road, for quality, for attribution to value-based care, for understanding of the needs of a population, for ongoing engagement in total cost of care and care delivery and care management opportunities, for coordination, streamlining with community-based organizations across social needs. Like, it could be incredible if we do this right. But I don't think it's a foregone conclusion by any means.
Yeah, one imagines the way you guys have described this as, like whips and like loops in a rope. Like, is this thing going up or down? It's the same strike, but it moves through finding people that were missing, reclassing the same person who was there. Somebody just maybe they actually have access to their partner's healthcare and just it's such a big pain in the butt that they choose it and there's savings. They're just robbing Peter to pay Paul. What net, Angie Inlow, I can't believe she's here. Thank you for joining Angie, who's now at Lumeris. Amazing. She's saying 10 to 12 million is what people are saying. When you pencil all that out, so some people are sort of screwed. Some people are just reclassed and are fine. Some people are moved on to commercial. What is the net? Is it 10 to, is it really 10 to 12 million? Is it half that? Is it more? How are you guys sort of finger in the wind handicapping it? And Avik, you have to take a guess too.
Well, don't make me go first.
You've all described these operations that you've got stood up where you have a pretty high hit rate, just making sure that they now comply with the new paperwork requirement. There's a little bit of a Soviet Union, like, oh, sure, you have to be that. Okay, you're that. Fill out this, sign this. Okay, here you go. Have a nice day. Give me some bread.
I'm happy to start, and then you should jump in. So the whole universe of members across Medicaid, I think our best hope at this point is to rely on the CBO, right? Like, they scored this thing, they're looking at the numbers, 10 million, 10 to 15 is probably reasonable. I think if I had to put money on it, I'd say it may end up being a bit higher than that, but we will find out, right? For Cityblock, however, I think because we care for high risk, rising risk individuals, disproportionately people with disabilities, people who are more likely to retain Medicaid even post the work requirements because they are so highly in need and so clearly in need, and because we have such close relationships with these folks that we can support them in getting through the process. We're less worried from our perspective about the members whom we serve. It has real impacts for the risk pool and for the movement of people that will impact basically every value-based provider in this space, right? Anybody who's taking risk in Medicaid needs to be prepared for a number of sort of macro impacts. One of them is that the overall acuity on average of people on Medicaid is going to go up. You disenroll people who are lower risk, lower cost. It takes a while for reimbursement rates and for rates and premiums to catch up. And so there will be what the plans are talking about in their earnings call as a sort of rate acuity mismatch, which means essentially on a per capita basis, on average, they're underfunded for the complexity and acuity on the program. That's a real thing. We saw that after COVID, after the public health emergency. It takes 12 to 18 to 24 months really for states to catch up there. The relationship between Medicaid and the ACA is going to be really interesting to watch, especially as those subsidies expire. And what does that mean for people who are sort of on the cusp, going back and forth? I think it's going to be very interesting. The impact on providers. Someone asked that in the questions in the chat. I think that's going to be really, really significant in terms of access to providers and their ability to serve these populations. That will impact us. And then the overall impact on state Medicaid budgets, what they can fund within the Medicaid program, all the other ways they have come up with of funneling support to safety net providers. Much of that's going to be curtailed, and that will have an impact as well. So lots of things here.
Avik, what's your over and under on the lives lost versus lives shifted versus lives just repapered and off we go?
Yeah, so I think it's going to be a pretty small impact, actually. The CBO has a fairly poor track record at predicting coverage coverage numbers over the years. Just to give an example, the CBO predicted that when the individual mandate was zeroed out in the ACA, that there would be 5 million fewer people enrolled in Medicaid as a result of that change. And in fact, Medicaid enrollment went up, not down. That's one of many. I could bore you with we could talk all day about the CBO's predictions and where they go awry. And look, it's a complex thing to predict, so it's not to hold them to an impossible standard. But CBO estimates are often taken, particularly in the press, as gospel in ways that don't actually reflect the accuracy of those predictions over time. And I would say in this particular context, I think the impact on enrollment is going to be significantly lower. I would say somewhere between 25 to 50% lower, or 50 to 75% lower than the CBO's estimates in terms of the loss. So I think it's going to be more like, let's call it 2.5 to 5 million in terms of the actual decrement coverage, and possibly less, for the reasons I mentioned before. That what you find is that people find a way to maintain coverage through various mechanisms, and some of it's what Toyin described earlier. Some of it's, again, the plans. The plans in particular have a massive incentive to get people covered, and while there may be rules in place to make it harder for them to be helpful, they still want to be helpful. Same with hospitals. So there are ways to kind of to blunt the procedural hurdles or address them.
Jim Hickman and Eric Threlkel are both asking questions around infrastructure, social services, resources that don't fit into the normal CPT code claim pay box that Medicaid game layer that states offer. You guys are very much non-box dwelling value props. Lots of robbing Peter to pay Paul, spending millions of dollars, finding people, mapping them so that you can navigate the ones that would have been your Camden case. Would you rather sell to a state that is sort of straight Medicaid, delegated to a plan, or fully block granted, to build their own sauce? How much does flexibility help you when you're selling today? How much is there out there to try these other, make investments in the non-procedure code stuff?
I can talk a little bit about that a lot.
You're talking about, we go to community centers that, might have arts and crafts classes for seniors, right? That's not that's not a Medicaid thing, So do you guys have markets where the plans, either the state or the commercial plan that's delegated, has more flexibility, and therefore it goes easier for people that are kind of new math players like you? Or is that not?
Well, I think maybe a corollary is like the 1115 waivers that have been there. So this kind of gave flexibility to the states, and that's one of the things that a lot of
that's a block grant, right?
Yeah, the health-related social needs were really financed by, candidly, they're very much at risk of going away. And so while places like, California and North Carolina have shown those flexibilities can have a positive ROI, New York is in the middle of one right now with it's called social care networks, so CBO networks. It's very much a question mark if they're going to be renewed at all. California just took the stance that they're going to move it all into their managed care benefit. So they're taking some of these flexibilities and moving into managed care. But what I think it has done is it's given us a playground to show outcomes, because that's one thing that's one loud and clear statement from HR1 is folks want this to be delivered more efficiently. They want to do more with less here. So payers are looking for the dollars and cents ROI with published papers and all of that. I'd much rather go to a state with those flexibilities, demonstrate the outcomes, and then help take those flexibilities and bring it to the other states under value-based arrangements.
I would just maybe to add on that, I think just being on the sort of difference between the 1115 waivers, which are some of the flexibility that states have leveraged to allow them to invest in things like health-related social needs, super supportive, because it really creates an environment for innovation and an acknowledgement that there are things that fall outside of the traditional Medicaid benefit that have real meaningful healthcare ROI if invested in appropriately. Different from block grants, right? Like block grants actually, I think, disincentivize some of the real innovation that allows you to invest upfront to reduce medical spend on the end, because ultimately they're sort of holding flat the estimated costs. Have seen it in different places. Maryland's an interesting place in terms of just sort of blocking, if you will, the acute care systems. But we see a lot of states experiment with the notion of block grants. That's sort of the opposite of the flexibility that I think has really been beneficial in both Trump 1 and in Biden, in allowing us to really try to innovate around value-based care in particular.
I might have my terminology wrong. So is block grant in your mind synonymous with budget cut?
Block grant is, yeah, it looks like, it looks a lot like,
I was thinking in terms of flexibility as a versus amount. Does a block grant synonymous with more flexibility or not so much?
less so, because basically what it does is it's a fixed cap on a state basis. So it caps the amount of dollars for Medicaid that go to states. They have to sort of work within their means around that. And typically what that means is that they lack the flexibility to say, hey, we'd like to fund X or Y. That's a little bit outside of the benefit. We'll match the dollars at the state that CMS contributes, which has actually been the genesis of a lot of these innovations. And Avik, you're the policy person here, so please feel free to school us a little bit more. But our experience has been that states have really pushed this have had a little bit less of a rich environment, particularly for innovation around health-related social needs, because the dollars just aren't there.
Block grants, technically speaking, are orthogonal to the actual amount of money. Block grants could result in increased spending. They can result in decreased spending. The whole point of a block grant is that you take the money you are already spending and just say, instead of the federal government spending it on your behalf and putting a lot of strings attached to it, you give that money to the state, and in theory, the state has much more autonomy to spend the money. And this is an approach that's been used in welfare reform and a bunch of other education funding setups, things like that. So in theory, the idea is that if you give the money to the states will have more flexibility, and they can do things like invest more in social determinants and other things that right now, the way the Medicaid program is designed, in theory, the states don't have that flexibility to reallocate resources according to where they think the population requires more help versus less. What I've observed in practice, so I was kind of encouraged by what you guys were saying earlier. What I've observed in practice is that state flexibility in the Medicaid context doesn't really seem to amount to much, because what I observe is that CMS will put out these waivers, they'll put out these blueprints and say, hey, we're giving you guys all this flexibility, please go do stuff. And then the state Medicaid directors kind of look with deer in the headlights looks and just say, oh my God, I'm going to actually be now responsible for decisions that might actually mean that people get mad at me if I make a decision that's different than what the government's forcing me to do. This is terrifying. And the whole kind of ecosystem of state Medicaid directors is, no, don't give me flexibility, because if you do, then I'll be accountable if things go wrong. There's a risk aversion problem with the decision makers in these state capitals. So at least that's what I've observed. And I can tell you at the CMS level, this has frustrated a lot of CMS administrators who say, hey, you guys keep telling us you want flexibility, we give it to you, and then you don't actually do anything with it.
Now, Hickman Jim from Camden is in the chat talking about that the 1115 waiver actually theoretically has a positive ROI criteria to it, but it sounds like in real-time manifestation, Toyin's experience is that, yeah, but the code is the block grant is a shrinking daisy, and the 1115 waiver is a growing daisy. But theoretically, both aspire, at least the 115 as an explicit. And I guess Pair Team's an exemplar there. I think of you both this way, doubling down on some people, regardless of what the CPT codes would have shown, and then having a downstream, robbing Peter, pay Paul, do a lot of social services, do a lot of navigation, and end up with, a dog that didn't bark in the emergency room in the OR. Does block grant ever turn into just commercial, just moving the Medicaid plan to a commercial player that's easier for you guys to work with? Is it easier? Is it easier to work with a commercial plan that's managing Medicaid or a state?
I think it's hard to work with states in general. I'll just say that the procurement process of working directly with them, we've had some discussions with folks and haven't gotten there yet. So Toyin, if you've made some of that work, I would love to hear your experience. So we work exclusively with the managed care plans.
Same here. We work directly with managed care plans as well.
So it's not so much the waivers and the block grants. It's more, is there a more commercial entity to do business with representing those CAID lives? And whether they get their money with block grants or 115 waivers or, rain dances, who cares? The point is there's a commercial entity with the provider relations. There's a machine to work with.
That's right.
Interesting. Health plans organize markets. The famous Medicaid experiment of Oregon. Or Avik, tell us.
Well, there's a comment in here from Don Ross about how Oregon voluntarily took on some risk in exchange for flexibility. And actually, there's a lot of history with Medicaid has become famous because actually prior to the ACA, there was an expansion of Medicaid that CMS helped fund where they ran out of money because there were so many people who wanted to enroll, or the cost of the enrollment was went over budget. And so some people were on Medicaid and some people were not. And a bunch of economists published an interesting study about how the people who enrolled in that Medicaid expansion did versus the ones who didn't get Medicaid. It was seen as one of the few natural experiments in health policy.
And maybe just to put the fine point, I might put you on the spot a little bit over, but I mean, to the point around like, it really matters whether the CBO estimate is correct or whether there are other places for people to get insurance. Because my recollection of that study is not surprisingly, health insurance is a meaningful determinant, or at least it's meaningfully correlated with health outcomes, right? And so it is interesting to think through how, like, even if there's a temporary dislocation in a person's insurance coverage through this, it can be impactful.
Well, that one actually showed that there wasn't an improvement in health outcomes, which is one of the reasons it became famous as a study, because it was a very surprising result to a lot of people. But certainly, I think everyone on this call can agree that it's a good thing for people to have health insurance. And I think the quality of the care you get and the access to care is really important, which is why what you guys do is so important.
When you guys deal with these Medicaid plans, how much flexibility do the plans have to spend money in sort of non-traditional ways? Is it open-ended? Is there a report they've got to do? How much flexibility are we really talking about? Or is it just there's a person to call and do business with and negotiate with, et cetera?
I think depends what you're doing for the plan. I think there's two pathways to work with the plan. You can work as a provider or as a vendor there. And if you're in a vendor and working on more compliance, like delegated care management, then there's just a ton of rules there, which the plans don't really want to hand off. But under provider value-based care arrangements, and what we're seeing with HR1 is that they want to show the dollars and cents and the ROI for all of it. And so you do have flexibility there. You can get, delegated. The risk plans are pushing for, at least what we're seeing is 100% of fees at risk there, along with shared savings on top of it, just because that's the financial environment, the constrained financial environment they're in. But with the dollars that they do give us upfront in terms of, we get per engaged member per month rates there, you are free to, there are, of course, some contractual requirements that you have to adhere to, but you can also then use it in odd and ends ways and supporting a member on, a grocery delivery drop off, for example. And so there is that flexibility if you carve the contract out in the right way.
Yeah, and I think obviously the plans are very acutely sensitive to the notion that they're seeking to see a return on their investment in the form of improved quality, better engagement and member experience, less churn potentially, as well as reduced total cost of care. And so really interested in figuring out how to invest in those types of interventions. We see a lot of the markets in which we operate, we're in 11 states now, have some sort of what would be a little bit more considered more innovative approach to offering flexibility at the state level to support health-related social needs. And of course, on the dual side, the supplemental benefit structure through Medicare Advantage enables some flexibility there and some differentiation as well.
You guys are both sort of, let's call it 50-state aspiration companies, 11 now, but hey, stay tuned, right? And you have a differential model, earn the right to navigate, earn the right to hold the hand and then navigate. What are the other things you like to see in place? I'll give you an example. In Maine, it's been a battle to get acceptance of community paramedicine, but we're a massively rural state, and driving 6 hours to get an IV at the hospital is absurd. But that's what happens today, as opposed to, somebody, a sprinter or ready responders, or just the local fire department making some extra money doing stuff. Virtual specialists. We've seen our first digital first, musculoskeletal IPO. Like, what are the things that you like to see in market after you see a commercial carrier taking over Medicaid that you can do business with and flexibility? Like, what are the other nodes in your ecosystem that make you more effective?
I think behavioral health, both access and integration is a big one. So states that choose to carve out behavioral health, it's harder if you're seeking to integrate physical and behavioral health care at the point of need and the point of care to the member if there's two separate payers. California is a big state for where that complexity just adds another layer. So that's one. I think we really like to see states. I'm a huge proponent of community paramedicine for sure. And so, yeah, I spent a lot of time in Massachusetts over a decade ago, building out and getting regs promulgated that allowed us to do that. I think it's huge. I think that
was my first business plan in 1991.
I mean, it took us until 2012, I think, or 2013 to actually finally get the regulatory approval to do it. It's massively impactful and I think so important. And I think more broadly, there are a number of, scope of practice regs that are meaningful that impact whether, it has to be a nurse doing X versus a paramedic versus a whomever. All of those things matter a ton in value-based risk relationships. At the sort of federal level, we do think that there is opportunity around clarifying. You were talking about TEFCA earlier, but as we increasingly, hopefully, leverage technology and digital means of engagement with members, the ability as a value-based provider to, under the sort of intent to treat mandate, to actually outbound text people and initiate SMS and other digital communications is huge, 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 which will allow us to sort of unlock these sort of otherwise prohibited means of communication under the HIPAA. And so there's something that's really important there that I think the states don't have flexibility really to do much about, but I think we have an opportunity at CMS to think differently about. And then we saw actually in the debate around the One Big Beautiful Act, there was a lot of back and forth around whether or not we would have state-specific rules around AI. This is not just healthcare, but sort of across the board. And at the last minute, it was pulled out. And so essentially there is no moratorium on state-specific AI regulation, which means that we are already seeing individual states regulate the use of AI piecemeal. And that will create this sort of patchwork of regulatory, it's happening right now, honestly, that will make it very difficult for multi-market state organizations to operate across states. And you combine that with the lack of clarity. So we've got a sort of a no moratorium on states doing whatever they want and no real clarity, I think, from the federal government, particularly in healthcare as an important use case that I think AI can be transformational for. I think we're going to find ourselves with a really, really complex patchwork of regs to navigate through as we seek to scale AI-driven care modalities, which is
Okay, so mental health and as much blue sky reg as possible. Neil, you partner directly with these community-based organizations. So what do you look for? Any building on Toyin in terms of what you look for when you to pick out a state where you feel like you'll crush it?
Yeah. I mean, there were a couple things in there. The scope of, I think Jim was mentioning, the scope of practice and expanded provider types. They also just show you how the state is thinking about this. Can NPs be a PCP of record, for example? They're an NP expanded scope of practice. I think the other part that I do want to just double click on is the AI component of it, because we've been talking to, met with like Dr. Oz and folks at CMS, and we're going through this inflection point of not just texting with patients, but actually voice calling with individuals, right? We're going to see a lot more of that with voice gen coming out. And this patchwork of AI regulations is going to make it very difficult. And then you have folks like Texas that just put together an AI sandbox, where they want to test and measure the outcomes and impact of these AI solutions. So that's a little bit more forward facing there. So we are looking at states that are leaning into that, because our goal at PAIR is, you can essentially think of it as agentic social infrastructure there across community-based organizations, and putting in, doing a lot of social work can be administrative in nature, that agents should be able to drive outcomes, help folks focus on, the care and the connection part of all of it. So we look for states where we can build that sort of infrastructure and take our model from high needs to moderate and low risk populations to kind of care for the full gambit of the safety net.
And I will throw in, hopefully for you, you will find more and more states with fewer information blockers. We still have lots of medical record systems and providers on systems not responding, which makes it harder for a longitudinal provider such as you guys who span many specialists, many hospitals, many emergency rooms on the same person, to keep a holistic picture. And hopefully that will, as with this attribution and enrollment and sort of paperwork layer, be a pig that gets through the python and then becomes the new normal. This has been phenomenal. We are at the 5 o'clock mark, so I will check the box, declare a screaming victory. Thank you all very much for joining us. Toyin, Neil, and Avik, this was phenomenal. And all of you who joined us, a great crowd of legendary, all of you, Jim and Haycraft and Angie, you should all be on these because you all know just as much as the rest of us on this screen. Thank you very much. Take care, everybody, and have a wonderful weekend or week or whatever we're at.
Bye, everybody.